This is for New York City Adult Behavioral Health HCBS Plan of Care Workflow Training. This is an updated workflow on the Plan of Care that we will be presenting. My name is Boris Vilgorin, and I'm with the Managed Care Technical Assistance Center of New York, which is part of NYU. And I am happy to announce that we have our state and city partners joining this presentation, both to walk us through the workflow, and also we have a lot of time at the end for any questions that might come up. So without further ado, we'll jump right into it and go through the presentation. Okay, so again, as I mentioned, the agenda is we'll do a very brief overview of MCTAC, just for, I suspect by now, a few folks on the phone who might not know what MCTAC is. Where, of course, the main event will go through the Adult Behavioral Health Plan of Care workflow and really touch base on the non-medical transportation. Okay, so what is MCTAC? MCTAC is a training, consultation, and educational resource center that offers resources to all MH and substance use disorder providers in New York State. And our goal is to provide training and intensive support to all providers in New York, with an overall goal for preparing and assisting providers with transition to Medicaid managed care, and of course with HCBS and HARP. All right, the two main partners of MCTAC is McSilver Institute, where I reside, and which is part of NYU, and we have our partner Casa Columbia, which is our substance use disorder partner. In addition to the two partners I just mentioned, we also partner and work together with CCSI, NIAPRIS, IDEA Center, and ICL to help us implement and work together on this initiative. Okay, so as I've mentioned before, our main goal is really to go through the adult behavioral health workflow. But before we jump into it, I do want to mention that these slides will be available on our MCTAC website, which is mctac.org. And we're also recording this session, so the whole presentation will be available as well. So with that, I will turn this over to Charlotte Carrito, who's going to walk us, and Maria Abraham, who's going to walk us through the workflow. And if you guys want, I'll be more than happy to, switch the slides for you. So you just let me know when you want me to move to the next slide. So Charlotte, Maria.
That'll work perfect. Thank you, Boris. If you don't mind controlling the slides, that'd be great.
Not at all.
So first of all, welcome everybody. We really appreciate you joining the call for the long anticipated unveiling of the Plan of Care workflow. As you all know, we have been working very diligently to create a workflow that will allow us to get started on January 1 to start moving people towards HCBS services and to getting people access and engaged in those services. And this has taken a couple of different forms as we've worked through it. And what I'm going to present today is going to be a workflow that we know needs a little bit of work. But I do think that we're in a place now where we're going to be able to take, where we've been able to take all of the CMS requirements that we need to meet in order to be able to provide HCBS services, as well as making sure that there are touch points with the managed care company to make sure that providers are going to be paid appropriately, and that we've tried to squish that all into one workflow. So we recognize, like I said, that there's going to be some modifications to this once we let this out of the gate and we start to see best practices emerge. We are anticipating that plans and providers may come back to us with some interesting solutions and some creative ideas about how to improve this. So, we just want to we want to just put that up front because we realize that this is new for everyone, and it would be highly unlikely that we would get this right 100% right out of the gate. So again, we appreciate everyone's patience. We know there's a lot going on. There's a lot to absorb. There's a lot to implement, and so this will hopefully help to move us to the next step in the managed care transition of behavioral health services for New York City. And also, we wanted just to talk a little bit about, you know, the expectation of getting everybody assessed. I think that we, you know, the state realizes that, you know, as of January 1, there is no possible way that everyone who is HARP eligible and enrolled or not enrolled in a health home will be assessed. So, you know, I think that you're going to start to see some guidance coming out from the state around some performance expectations and how we are going to systematically and strategically put in some benchmarks around making sure that we are getting people enrolled and assessed in a way that also allows this new developing service array to develop. So, you know, again, I just want to put that out front because I think, you know, there's a lot of talk about there's no way, you know, that all these people are going to be assessed on day one, and it's true. And we're aware of that, and we're looking now to do some data-driven analysis to really start to figure out, you know, by March, where do we hope we're going to be, by June, by this time, you know, next October, and by January of 2017, where are we going to be. So, so that is just, I was trying to channel Tom Smith. I know Tom Smith typically presents these kinds of things. He couldn't be with us today, so that was my best Tom Smith channeling for the moment. So diving into the workflow, we are going to look at this slide. We recognize again that this slide is a lot to take in. Just to orientate you a little bit to the slide, there's some key terms up in the right-hand side of the slide, and on the bottom, the footnotes are typically those things that are either a CMS requirement that need to be somewhere in the workflow in order to meet the CMS requirements for HCBS plan of care, and also some of the language that is actually in the Medicaid model contract that help us to distinguish timelines and timeframes between plans and providers in terms of being able to authorize and approve services. So the purple boxes that you see in the middle is really where the tasks and the action between the plan, the provider, the health home care manager, and the individual, where the work is really will be done. So in Section A, basically we start out with an individual who's enrolled in a health home, and the community mental health assessment is conducted by the health home care manager, and then it's determined at that point whether the person is eligible for HCBS services, and if they are, then the full behavioral health HCBS community mental health assessment is conducted. So that's kind of where we start, and then the plan of care begins in box B. So if, Boris, if you don't mind flipping to the next slide. All right, so so step B, what we've tried to do in this slide is really to break down the task into the different roles for the people that are involved. So in step B, the health home care manager develops and submits a proposed plan of care, and the managed care organization approves the plan of care. So in the health home care manager, their role in this step is really to identify with the individual their goals and the HCBS, the behavioral health HCBS services that will support the individual's goals. From there, the health home care manager provides a list of in-network provider for the individual to choose. And we did leave a little room here. At this point, the health home care manager can actually contact a managed care organization to talk with them about in-network providers. We recognize that a health home and an individual that may be in your health home could be in one of many plans, and the way that plans have contracted with HCBS providers could vary plan to plan. So it's important that the health home care manager either has a list at this point of contact or that they reach out to the managed care organization to get some guidance around who's in network, so that we're giving the individual a realistic picture of what providers they can choose from to get whatever HCBS service makes sense for them. So, so then the proposed plan of care is submitted with the services that the individual and the health home care manager have determined will meet the individual's goals. And that is submitted to the plan, and the proposed plan of care is then submitted to the plan for a level of service determination. So there's been some discussion about what does the level of service determination mean, what is that, and you know, what exactly does that mean? It's very similar to the level of care determination and the ACT process. And basically what the level of service determination is going to do is it's going to alert everyone that it is okay for that individual to receive the HCBS service that's in the plan of care. So for example, if somebody is going to be receiving CPST, that the health home care manager and the individual decide that is going to be a service that the individual is going to need to get to their goal, then the plan approves that level of service, and under that level of service determination, there are at least 3 visits within 14 days that will be covered under that level of service determination. So once the plan of care is approved, like I said, the level of service determination is issued, and the authorization for at least 3 visits to the behavioral health HCBS provider that service is listed in the plan of care will cover 3 visits and within 14 days. And that level of service determination doesn't start, those 3 visits don't start until the first visit. So if I'm a person and I come in today with a level of service determination for peer support, the peer support provider has 3 visits within 14 days to figure out what the frequency, scope, and duration is going to be needed to help the individual ultimately reach the goal. So in step B, there's actually not a lot for the HCBS provider to do in this case. At this point, they're still waiting for the individual to have an appointment and to come in for their first visit. All right, so next step, if you could go to the next slide. So in step C, the health home care manager with the MCO refers to the behavioral health HCBS provider. So in this step, the health home care manager is really going to help with the warm handoff and engaging the individual with the in-network behavioral health HCBS provider of choice. So it's in this step with the health home care manager and the individual that things like doing a 3-way call or calling with the individual to the HCBS provider to help make sure that an appointment is scheduled is really, really crucial. You know, those are those really tenuous moments in care where we can lose someone. So we want to make sure that that is really the health home care manager's role in this step, to really help that person get connected. And we also realize that in terms of the overall timeline, the time between that interaction with making an appointment and the person actually going to the HCBS provider in person, that time frame is going to vary depending on just appointment availability and things like that. So the HCBS provider in this case will be, the individual will be coming to the service. And again, like I said in the last slide, the HCBS provider will have 3 visits or 14 days, whichever comes first, for the provider to assess for frequency, scope, and duration of the service. And again, we can't stress enough that in every part of this process that the individual really needs to be a part of the conversation, and that everyone needs to be really thinking about how these services can actually support the overall individual's goal, whether that's to get a job, whether that's better relationships with their family, whatever the overall goal is of the individual, that this is the time to really put a plan together to look at how often does the person need to come, to what extent do they need to come, and over how much time do they need to be engaged, do we think, for them to be able to reach the goal that they're really looking for. And so the MCO's role here is to continue to work with the HCBS provider and the health home care manager and the individual to offer support and further coordination. There are multiple people in this process really trying to support the person towards the overall goal. And so at this point, we're really wanting to make sure that all of these parties, that there's a fluid ability to communicate to really make sure that we're putting together a plan for an individual that is really going to support them towards rehab and recovery. Okay, so next slide. All right, so in Step D, the MCO authorizes the behavioral health HCBS services, and the health home care manager implements the plan of care. So essentially here, once the 3 visits and, sort of the assessment at the HCBS provider level is completed, the HCBS provider is going to contact the managed care company and get an initial prior authorization for the service that they're going to be requesting. So it's at that point that the HCBS provider, along with the managed care company, engage in a direct dialogue that will really flesh out the frequency, scope, and duration of the service. And at that point, the HCBS provider is also going to want to make sure that the managed care company is aware that the 3 visits in 14 days has happened, so that there can be an authorization number attached. It's not that a prior auth is needed for that 3 visits in 14 days. It's really just to make sure that there is a claim number that can be attached to that so that the claims will pass through and they will pay. But the prior authorization is also done at this point of contact in order to make sure that there is frequency, scope, and duration, the managed care company, and looking at, because now they're going to have the whole plan of care. They're going to be looking at that plan of care and making sure that frequency, scope, and duration makes sense in the overall scope of the individual's treatment plan. And this can be, an example of this could be someone who may need some HCBS services but also has weekly dialysis. We want to make sure that in that plan of care that whatever we're proposing for them to meet their goals, that it aligns with meeting, all of their health issues to be able to move them to a better place. So we want to make sure that the services that are set up for HCBS aren't interfering with perhaps some of their other chronic medical issues that may need to be attended to as well. So it's at that point that we're really feeling like that's the place where that conversation is really going to take place. And then once that prior authorization is given to the HCBS provider, the HCBS provider is going to contact the health home within 3 business days of receipt of the authorization to ensure that the engagement is happening and to really talk with the health home around the scope of services that were agreed upon. So then the health home care manager in D3, the health home care manager is going to update the plan of care as necessary and share with the individual and the MCO. And that's going to become an ongoing process between the HCBS provider, the health home care manager, and the individual. And in between that, the MCO is going to approve, like I said, they're going to do a prior authorization for the frequency, scope, and duration that's being asked for by the HCBS provider. And there are certain timeframes attached to that per the model contract, and with within 3 business days of receipt of the information and no more than 14 days after receipt. And then there is a potential for an extension per the contract if need be, to gather the information necessary to render a prior authorization decision. And the MCO is going to send the behavioral health HCBS provider, the health home care manager, and the individual a prior authorization letter to alert everyone to the services that have been authorized. And then if you go to step E, next slide, this is where the ongoing monitor of the care and the care coordination with the plan of care really takes off. So it's at this point that anytime the plan of care is updated, that the health home knows if there's any sort of life-changing event, the plan of care needs to be updated and needs to be reflective of whatever new services may be needed as a result of the life-changing situation. So it's in this step where everybody is just going to be in an ongoing monitoring place, and this is really where the care coordination pieces are going to take place between the individual, the health home care manager, and the HCBS provider in partnership with the managed care organization. And
all right, Charlotte, I think I'm going to switch back to this main slide.
Sure.
And so this way, if there's any other things you want to cover, and then we'll jump back to the next next portion.
Okay, so that is, that is basically the pieces of the plan of care workflow. The one thing I will say is that it is in step B that the health home care manager and the managed care company are going to be in conversation to get the plan of care approved. And it's in step D that the behavioral health HCBS provider will be in conversation with the managed care company to get a prior authorization for the service. And it's in step C that the coordination between the health home care manager, the HCBS provider, and the individual, that's really where the work of getting someone engaged actually happens. And so hopefully this workflow at least parses out and people can really start to figure out at what points are they engaged and responsible, and where just an overall shared responsibility for care coordination needs to occur. And so I think that's all I really have to say about this, and then it sounds like we'll do questions at the end.
Yes. Great, thank you, Charlotte. And yeah, that's correct. We'll do questions in the end, and I'm going to invite folks to chat in the questions. It should be on the bottom right, and then as we finish this presentation, we'll go to that portion. So now we're going to jump to the next portion of the presentation on slide 12, hopefully. Yes, and I'm going to invite Alyssa. Hopefully you're with us. You might be on mute or maybe not anymore, to walk us through the non-medical transportation slide, and also wanted to tell folks that I think it was today that we sent out an invitation for folks in January 6th, if I'm not mistaken. We'll do a more in-depth discussion about this, and with that, I'll turn it over to Alyssa.
Hi, this is Alyssa Slezak from the Department of Health. I do just want to say that the non-medical transportation portion of this presentation is pretty much exactly the same as what was in the first presentation. Just want to start off by saying that nothing has changed. The reason why we're including this in the presentation is because it is related to the plan of care and the services that are in the plan of care. So while we may have changed the words on the slide, the concept has not changed, and the roles and responsibilities of the parties involved have not changed. So just reminding folks that non-medical transportation is an HCBS service that's going to be available to people in HARPS and HIV SNPs if they're eligible. It is different than regular Medicaid transportation, which is transportation to and from medical appointments. However, it is going to be paid and treated the same as medical transportation in that it is fee-for-service, so the plans will not be paying for it, but because it's an HCBS service available only to those in HARPS and HIV SNPs, there are some roles of the plan in this process and also of the care manager. So the two types of non-medical transportation that would be covered are trips to and from the behavioral health HCBS that are in the plan of care, and also trips to and from non-HCBS destinations that are specifically tied to a recovery goal that is in the plan of care. And we have on the next slide a link to that guidance. So if you're wondering about trips that qualify for the non-HCBS destinations, you can look at that manual, and we'll also be addressing that in the webinar that you just mentioned. So just a reminder, health home care managers are going to be completing the grid that we'll be showing in just a minute, which will involve listing the behavioral health, home and community-based services that are included in someone's plan of care, and also any other non-HCBS trips that qualify that they would be including. And this would be forwarded over with the plan of care to the plan, from the health home to the plan, and then, you know, when the plan approves that, they would be forwarding that to Logisticare in New York City, which is the transportation manager, and we will discuss that in more detail at the next training. But just to remind folks that, you know, this document is tied to the plan of care. The grid only needs to be inclusive of the trips that are for non-medical transportation. Everything else with somebody's regular Medicaid transportation would follow the exact same process that it follows now. And then again, the link will spell out these roles a little bit more and talk more about the type of trips that are covered. There is a $2,000 cap on this service. However, that cap only includes the trips that are to non-HCBS locations. It does not include the behavioral health, HCBS, or public transportation. So that's all I have for non-medical transportation. This is just a picture of the grid, and that's also online in that manual. We are going to look at making this a fillable form, and we'll be discussing that more in the webinar that's upcoming.
Great. Thank you, Alyssa. Appreciate you walking us through this. And so let's we wanted to, anytime we have an opportunity and have a lot of folks, and we have actually over 600 attendees, just reminding folks that communication is key in all of this. I think you've heard that throughout this presentation. And so we do get a lot of questions on how information is shared between managed care and HCBS providers and health homes and so forth. And so our you know, advice is always, especially, you know, for the CMAs, the case management agencies, please be in touch with your lead health homes, you know, in regards to that communication and establishment, you know, on those protocols. And the HCBS providers should be in touch with the plans they're contracted with and the health homes as well to understand, you know, the communication flow at this time. But, you know, but especially for the health home case management agencies, we wanted to remind folks to be in touch with them as well, as we know, and hopefully the health home leads are on this call as well. So with that, just wanted to remind folks that we have a lot of information, and as I mentioned before, these slides and the recording of this will be posted at the MCTAC.org website. If you do not get a chance to ask questions today, or during this presentation, please feel free to send us questions at mctac.info@nyu.edu. And with that, let me just turn to the questions we have been getting and kind of take us from there. So the ones that I think I can answer, I'll try. If not, I'll call on our state and city partners to help out. So the first questions are, we have been told the referrals will be starting for HCBS in January. Has it been revealed if this is going to be high percentage or low percentage come January 1? The question is based on how heavy the volume will come January 1st. I don't think there was any indication on if it's going to be high or low volume. I think, Charlotte made some reference into, this is definitely work in progress and folks still have to be assessed. I don't know if anybody from the state would like to add to that answer.
I think that's right, Boris. This is Charlotte. I think that what we all recognize is that there has been, because this is a new and ever-evolving process, we are all ramping up to make sure that this is successful as possible. And I think that we can understand the number of people who are enrolled in a HARP, the number of people who are enrolled in a HARP and a health home, and start to figure out what should people start to be expecting as far as volume as we move into the new year, into summer, into this time next year. So I would just say that, we are going to be taking a data-driven approach to this, and that there will be more to come on that. And I think that that's really the message at this point.
Okay, thank you. Has there been a decision regarding if living in a shelter disqualifies an individual? I don't think that we did a number of presentations with a grid on settings. I have not heard any update yet to that, so I don't think there was a decision made. But again, I'm going to pause and see if there's any change to the settings and disqualification or for HCBS. Okay. Is there a rate code for these 3 visits? I assume the question is in regards to the HCBS providers doing those specific assessments for those 3 days or 3 visits, I should say. My understanding is there are no specific rate codes for it, but there are rate codes and rates associated with each particular HCBS services. And my understanding is that those rate codes and those rules should be applied when doing these assessments. Again,
correct.
Is there, is that correct?
That's correct, yes. So I would encourage everybody to use the HCBS billing manual to reference the rate codes, and that the level of service determination will cover the first 3 visits within that 14-day period. So one of the questions that's come up in the past has been, well, what if the 3rd visit falls on the 16th day? My suggestion would be that, if you've seen the person and they're going to fall outside the 14-day time frame, and you've seen them twice, and you have an idea as to what it is that they're going to need in terms of frequency, scope, and duration, you need to call the managed care company and get a prior authorization. It's that first 3 visits within the 14 days that will be covered under that level of service determination. And when you call the plan to get your prior authorization, at that point there should be a mechanism on the plan side that will make sure that your claim will pass through and get paid for those first 3 visits.
And Charlotte, this is Yumi from the city. I just want to clarify, those 14 days are calendar days, correct?
Yes.
Okay. Yeah, we did get a couple of questions on that, so thank you. So those are calendar days, not business days. Let me see what other questions we have, because we have some questions that are very similar. Again, the expectations and how plan of care will be transferred. Again, this goes back to the communication. Please, if you're a CMA, please be in touch with your lead health home or managed care company in regards to the communication and transferring of the information. Just to clarify, the HCBS services and MCOs now discuss the frequency, scope, and duration, then not the health home care managers, right? So the question here is the change from the initial presentation of the flow to this one is that the HCBS provider, after the 3 visits or 14 days, discusses directly with the MCO the ongoing frequency, duration, and scope I think if I remember correctly, the initial one had the health home care manager involved, so I guess the answer is yes to this question.
Yeah, if you don't mind, Boris, going back to
please.
the workflow.
Yeah, definitely.
Because I do think that is probably one of the bigger changes as this process has unfolded.
Yeah, let me see here. No, went too far here. There you go.
Is that what happens between the health home care manager and the managed care organization is that initial contact to alert the managed care company of what services that we feel like the individual is going to need to reach their individual goals, and to make sure that choice has been provided to the individual in terms of in-network providers. So it's at that point that the level of service determination is rendered, and that also at that point, that's when the plan of care is quote-unquote approved by the MCO. So then frequency, scope, and duration is done at the HCBS provider level, because the authorization will ultimately be at the provider level, and the provider is really going to be the one who's going to be able to assess for frequency, scope, and duration, since they will be the expert on their service and what their service may be able to provide in order for the individual to reach their goal. It's at that point that the frequency, scope, and duration is determined, and a prior authorization will be rendered.
All right, thank you. There's a question on the medical, I guess, non-medical transportation. Does the BH-HCBS provider need to have a direct contract to provide transportation services? We subcontract all of our transportation to a vendor. So my understanding, again, for the Medicaid, healthcare, kind of the patient, healthcare specific, those continue as is. For the non-medical transportation, there'll be a webinar on January 6th that will cover more on what are the requirements and who can do that, and I'll turn this to Alyssa as well to add to that answer.
Yep, the only providers of non-medical transportation are those who are Medicaid transportation vendors that have been certified by DOH. So there is an application process on the DOH website. We did make this announcement because originally we had asked providers of HCBS services to apply to become designated to become non-Medicaid transportation providers, and we later made the clarification that if those providers were interested in providing this service, they did have to become Medicaid transportation vendors. So, and that Great. Will be discussed more in the webinar. Thanks.
Thank you. Next question. We were told that patients have an option to refuse health home case management services. How does that affect the assessment for HCBS services? That is correct. Some of the individuals could opt out from health home case management services. There is a process which managed care can subcontract with a designated entity or health home to conduct the assessment and development of a plan of care. However, that individual will not be enrolled in the health home, and the ongoing case management will be handled by the plan themselves. I just want to, again, pause here and make sure I got that right as I pause and check with my state partners.
So those individuals, and I'm going to invite Alyssa to chime in here if I get this wrong too, she can keep me honest, but I think that those people that actually opt out of a health home, we have a very loose sort of workflow right now for that situation, and we are working diligently right now on really honing in on the specifics of what that's going to look like. I think Boris kind of said exactly what we've to date have gone out with, but we will be providing more information on that to come. Back to the original, kind of to the introduction of the workflow. Our priority right now is to focus on those individuals who are HARP enrolled, who are health home enrolled, that we already know. I mean, there's already about 12,000 HARP and health home enrolled individuals that need to be assessed. And that right now I think is our priority. We know where those people are. We know that they will most likely be eligible for HCBS services. So we're going to, again, be very mindful of the way that we ramp this up and the way that we're rolling out the assessment process, the HCBS services, and how we're moving people through this process. So there will be more to come on that, but our preference right now is really to focus on those people that we know that we have contact with and get them through the process.
Great. Thank you. A couple of questions in regards to kind of, I would call them general HCBS questions. Are 18 to 21-year-olds eligible for HARP HCBS services? The answer is no right now. It is 21 and older who are eligible. The under 21 would be part of the children rollout, which I think at this point is expected either late next year or 2017. But again, just to remind folks, the HARP eligibility is determined by the state, and those lists were shared with managed care companies at this point. There's also a question on what are all, yep, go ahead.
This is actually a very good question. There is a lot of nuances to the transitional age youth and how what the impact is on that population as we transition to the behavioral health benefit before everybody's in. And right now we are working on some guidance that's very close to being finished that will give a chart of the different buckets that a transitional age youth may fall in and what services are covered at what age and with what payment structure. Is it fee-for-service? Is it managed care? To answer the question directly, Boris did a great job. It's exactly right. HCBS is only for 21 and up under the 1115 waiver. However, they are eligible for state plan services at 18, PROS, ACT, those services. So again, we recognize that this is a point that's difficult to put your arms around. We are working on getting some very concrete guidance out there, and it should be forthcoming probably very shortly after the beginning of the new year.
Great, thank you. So there's a question on what are all the HCBS services. I would strongly recommend folks go to the MCTAC website and OMH, OASIS, and so forth. There's a lot of information, both presentations that we have done and webinars. There's a manual that really goes into depth on not just listing the services, but also what they are and requirements. So I would strongly recommend folks that look that up and get familiar with that. So there's a question: what if the individual is approved for multiple HCBS services? If one HCBS provider completes their assessment and coordinates with Health Home, do they have to wait for all other HCBS providers to submit their scope? So I guess this is an assumption or potential situation, I should say, where an individual is approved for multiple HCBS services and chooses to go to multiple or different HCBS providers to receive those HCBS services. And I guess the question here is, would that slow down or stop the plan of care process or somehow impact one provider who might be ahead of another provider? So any thoughts on that?
So this goes back to Box B, and Box B is where the Health Home is going to present the services that the individual and the Health Home Care Manager feel are important to meet the individual's goals. And the MCO is, it's at that point that a level of service determination will be rendered. So what happens after everyone at the MCO, the Health Home Care Manager, and the individual agree on whatever the HCBS services that the person may need? Say, for example, again, CPST, everyone agrees that that's needed, and perhaps maybe also peer services. So, and when the person's given choice of provider, they may choose 2 different HCBS providers for their peer services and then a different one for their CPST. At that point, you know, the first appointment is made, and there are 3 visits in 14 days for each provider to get their first visits and frequency, scope, and duration figured out. One provider may be able to get that person in the day after the level of service determination is rendered. Another provider, it may take them a week. There's nothing in this workflow that prevents that from happening or that prevents that from being okay. I think that we realize there's flexibility that needs to be there in order for everyone to get connected. The important part then is step D, which is once the service is prior authorized for whatever the HCBS provider is and for whatever service has been deemed appropriate to meet the individual's goals, it's at that point that it's between that the HCBS provider just needs to make sure they're looping back to the health home care manager to update the plan of care. So this process can be leveraged whether it's one HCBS provider providing 3 HCBS services or whether it's 3 HCBS providers providing different services.
Great, thank you, Charlotte. Next question is, can clients be eligible for more than one type of HCBS services and choose different HCBS for each service? That is correct. That is the individual's choice, and individuals might be eligible for multiple HCBS services. There's another question that's in regards to the...
Can I piggyback on that?
Yeah, please, yeah. Yep.
I'm sorry, I don't mean to interrupt. I just I think that the way that we're looking at some of these HCBS services, when we kind of look at them in totality and look at the services that are actually being offered, if there is a circumstance where someone is needing more than 3 or 4 HCBS services, we would probably want to really explore a state plan service. Something like the PROS program or a referral to ACT, if we're feeling like they need every single HCBS service, there may be another type, a service type that may support the person in a better way. So I think that, you know, just to keep in mind, there is going to be, you know, there are several HCBS services that work together to make a really great treatment package for someone, but if there comes a point where the person is truly needs every single HCBS service, I think we would really push people to think towards, is there a more comprehensive program that the person might be able to get their needs met in a different way?
Great. No, that was good. Thank you for expanding that, because that's important. The next question, will there be a list of HCBS providers that care coordinators can outreach, including respite providers, vocational, and so forth? I believe there is a list, might be mistaken, on the state website on all the approved providers, but I would also caution folks that not all HCBS providers are contracted with all the managed care plans, and it is very important to make sure that it's not that it's an HCBS designated provider, but it's also important to check with the in-network list of that managed care company. And of course, there's still a number of providers in process and contracting, and I suspect it'll be probably in place for a number of months, so that list probably would change. So I think it's important. My recommendation for care coordinators would be to work with the managed care companies to make sure that the referrals are made to the in-network providers. Alyssa, Charlotte, anybody else? Anything to add?
I just want to, Boris, this is Yumi. I just want to take this opportunity, since this is a captive audience and there's probably a lot of HCBS providers out there, to please notify OMH and the managed care companies if you've decided to put certain HCBS services on hiatus or inactive status, or if you've decided to altogether not provide HCBS services from January 1 and choose to go inactive for HCBS altogether, please notify OMH and OASAS as well as the managed care companies. Thanks, Barbara.
Great, thank you, Yumi. Another question on the non-medical transportation. Does the non-medical transportation cover transportation to state-planned services such as PROS? If not, is there a transportation method that would work for this? Somebody who actually oversaw PROS program can speak to directly. PROS definitely has a transportation, but that's through what I would call the routine Medicaid transportation process. But I'll let Alyssa jump in here as well and add.
Yep, you're absolutely right, Boris. That would be covered. State plan services would be covered under the regular Medicaid transportation. Non-medical transportation only covers trips to and from the HCBS and then those non-HCBS destinations that support care plan goals. And we will talk about that more in the webinar, but just because CMS does not consider HCBS traditional medical services, that's why the home and community-based services are covered under non-medical transportation. But yes, absolutely, if somebody was eligible to receive transportation through Medicaid, they could certainly use that transportation for a PROS program.
Great, thank you. So I know we're running out of time. We have, I think, 3 minutes left. So we'll take one more question. I would strongly encourage folks, if we didn't get to your questions, we apologize, but please send them into our MCTAC.info email. We'll be looking at all the chats that did come in and trying to respond to them. So there's the last question for now is, has there been any changes to allowing health home care coordinators and HCBS services to come from the same agency? My understanding is there has been no change, but I think I'll let, again, Charlotte or Alyssa respond to this.
Can you just repeat the question just to make sure I understand it?
Has there been any change in allowing the health home care coordinator and HCBS services to come, or I guess to be provided from the same or by the same agency?
Yep, this is Alyssa Slezak from the Department of Health. There has been no change as per the Health Home Standards document and what we've been discussing at the Health Home MCO work group meeting for those who attend that meeting. You know, that is possible provided that there is structural separation. So if folks want to look at the DOH website at the standards document and also at previous Health Home MCO work group PowerPoints, the guidance is there. There has to be administrative separation, meaning that the care manager themselves could not be also the provider of the HCBS services, and they would be reporting up to separate structures within the agency. So there is more on.
Just to clarify, it sounds like the health home, and keep me honest here, Alyssa, that the health home care manager and the HCBS provider could fall under the same agency, but there has to be different supervisory structures in place in order for the agency to provide both services.
That's correct, and in no situation could it be the same person providing both those services.
Great. All right, thank you. Thank you for everybody for joining us today, and I want to thank our state and city partners for participating and providing this information. I know everybody's tired of hearing me, but please visit the website and utilize our email. And you know, I wish everybody happy holidays and a great day. So thank you again for joining, and take care.